Good morning. I appreciate the chance to be here today. As Josh said, I am from North Carolina. I practiced there for 30 years, but actually just 5 days ago moved to Denver, Colorado. So while I'm here talking to you, my wife is home unloading boxes. So thank you all for that. I grew up in Ohio, in Columbus, Ohio, but my practice has been in the mountains, in a very rural area of the mountains of western North Carolina. We saw the opioid epidemic start about 20 years ago, and I've really been involved since that time, and it's kind of taken me down this road to where I am now. But I am at heart a primary care doctor. When I first started practice, we delivered babies, we did surgery on our patients, we took care of them in the ICU, we gave them streptokinase and TPA. We did everything in the rural area where I was. And over time, my practice has kind of gotten smaller and smaller to where now I just do addiction treatment. As I said, we just moved to Denver, Colorado. I'm going to continue to see my patients that are in North Carolina by telemedicine, which is kind of cool. Really, all of my practice now is doing addiction treatment and consultation for chronic pain patients. And as many of you know, we don't have capacity in most areas of our country to treat all the people that are addicted to the opioids. So part of my ability to be able to move was to be able to continue to see my patients. So I will share with you a lot today about non-opioid treatment of pain. I'm going to try to help us understand pain a little bit better. We don't get much education on pain in medical school or residency. I wouldn't say our education is wrong, but it has been very incomplete, so I'll try to give you a little more information to help you understand some of your pain patients and understand how to treat them a little better. I don't have anything to disclose. I do like to start with this quote when I talk that says, "Opioids are the most potent medications we have for treatment of pain." This is in the textbook of the American Society of Addiction Medicine on their chapter on treating opioid use disorder. It's a very common thing I hear as I travel around and listen to other speakers talk about how potent the opioids are. And what I'd like to share with you today is that there's no science that supports that statement. It's what we've all been taught, but the science actually contradicts that. Now, they are powerful medications, but they work more in a behavioral aspect than they do actually in a pain-relieving aspect. And that's part of what makes them problematic. So we're going to talk about that some today. So I also like to start off with kind of the big picture opioid facts. In the United States, we have 4.6% of the world's population, and yet we consume 80% of the world's opioids. So many of you have heard that. This is a quote that's been going around for a few years now. This came from a study several years ago. This really is a uniquely American problem. We prescribe way more opioids than anybody else in the world does. Now actually, Canada is similar to us. Per capita, they prescribe as much as we do, but their population is so much smaller. But when you go over to Europe, when you go to Asia, when you go to Australia, they prescribe just a fraction of what we do. They prescribe more like we did 30 years ago when I started practicing medicine. So we've kind of got into this. It's really been driven by the pharmaceutical industry. I know pharma pays for some of this conference, I'm sure, but they've been the drivers. They continue to be the drivers of our opioid use, and we need to change that, I think. So when I started practicing 30 years ago, I see some of you out there with gray hair like me, and you've been around as long as I have. When we first started practicing, we didn't prescribe many opioids. We prescribed them for post-op pain, but usually for 3 days or so. And we prescribed them for hospice care, for people dying of cancer. But other than that, we just didn't use the opioids very much. For chronic non-cancer pain, we basically never used the opioids. That was just something you didn't do. We're always very cautious about them. Even with the minimal amount we used, we still saw some people becoming addicted to them, so we knew how dangerous they were. In 1997, we prescribed enough opioids for every man, woman, and child to have the equivalent of 96 milligrams of morphine per person per year. By 2015, that had gone up to 640 milligrams per person per year. That's what we are prescribing. This doesn't count the illicit heroin and fentanyl that's out there. This is our prescriptions. If you look at that, that's the equivalent of 128 Vicodin tablets for every man, woman, and child every year. So again, I think we can all acknowledge that we prescribe a lot of these medications. Now, we are doing a little better than we did. The peak year of our prescribing was actually 2012. And since that time, prescribing has gone down a little bit, but it's still very high compared to what it was 15 to 20 years ago. This graph comes from the CDC, and let me just share with you, everything I tell you is supported by science and by studies, and most of my slides have these little references up here. You guys will have access to all the slides. My last 4 or 5 slides are all these references in the articles. I have all of these. If you guys want to see them, you can email me. My email is also at the end of the presentation. I'll be glad to send them to you. But this study here that is cited was from the CDC a few years ago, 2012. And that green line on top is the increase in opioid prescribing that I just talked about, that we saw during this time period. And the red line underneath is the increase in overdose deaths, going up in parallel. And the CDC came out with this report, and they said that with this report is when they really first started talking about it, saying that the incidence of opioid overdose deaths that we're seeing and the increase in incidence is directly related to our prescribing. So as I mentioned before, that the death line, or the prescribing line, went up to about 2012, and since then it started to come down a little bit, but the overdose deaths are going up even higher, and that's because now we have the illicit fentanyl and heroin that are available, which are much more deadly. But these people that are using the heroin and fentanyl, the great majority of them still start with our pills. So I still believe that if we're going to address this problem, we need to change our prescribing, and I'm going to talk about how we can do that as we go along further in the talk here. This report was in Journal of American Medical Association a few years ago. It's called The State of U.S. Health. They do this, I think, every 10 years or 15 years. And what it does, it looks at different disease processes and how many people are suffering from those. And they compare the time period from 20 years before. So they look at heart disease, lung disease, all these other things. But I pulled out the 4 that are related to pain. And that second one over is other musculoskeletal disease. And what it shows, what this report showed, was that during this time period, when we started prescribing so many more opioids, I mean, between 1990 and 2010, our opioid prescribing skyrocketed, and yet we have more people in pain than we had before. And there have been 2 other reports since then that came out after this. One of them actually came from my state of North Carolina, where they looked at everybody with chronic low back pain, and they found that the incidence, the suffering, the degree of pain of people with chronic low back pain had increased during this time period as well. Again, even though many of them are on opioids. So as we listen to the message from pharma, they will say we can't be restricting our opioids because we have people suffering in pain. And because of that, we have to have opioids available for people. And pharma pays a lot of physicians to say this. But as we look at the data, our increase in prescribing is not reducing pain in America. In fact, pain is going up. And some of that is because, as we'll talk in a little bit, for most people that are on chronic opioid therapy, their pain increases over time. It doesn't get better. So I think this whole problem has happened really for 3 reasons. And as a prescriber, I think we need to take some of the blame. I think it was done with good intentions, and I myself will take some of the blame. I listened to the Purdue Pharma rep who came into my office and said, if you're treating chronic pain, these people will not become addicted. The science shows they will not become addicted. You start them off on 20 milligrams of OxyContin twice a day, have them come back in 10 days. If they're not better, you double that dose. Have them come back in 10 days. If they're not better, you double that dose, and you go up until their pain goes away. And if they really have pain, they won't get addicted. I heard that. I prescribed opioids. I know of at least 2 people that died because of the opioids I started them on. One is a spouse of a good friend of mine, and that's a whole other story. We won't get into that. But I know, and I'm sure there are many more that I don't know about, that I started on the opioids, and the problem progressed without me knowing about it, and they ultimately died. So I take some of the blame for this as well. Again, I think we had good intentions, but we were misled. But I think much of the problem is because us prescribers, but also the public, we don't understand pain very well. We don't understand the opioids very well. The pharmacology we get on those are very basic. Again, I'm going to show you some more of what we know about what opioids do during this talk. But we also don't understand addiction very well. So we don't get very much training on any of that. We get way more training on lupus than we do on most of these problems. And most of the people we see that say they have lupus don't even have that. So much of what we're doing is disproving their diagnosis. So let's start. Let's talk about pain first. So this definition comes from the International Association for the Treatment of Pain. They are an international association that's a nonprofit organization. So most people highly respect these folks. We have a lot of pain organizations in the United States, but the great majority of them are actually funded by the pharmaceutical industry. So you have to kind of take what they say with a grain of salt. This one is not. I have a lot of respect for them. But notice that they say that it's not just an unpleasant sensory experience, but it's also an emotional experience. So I think one of the problems with our education on pain is we're taught about pain very much as a linear process. You stub your toe, the signal goes through the nerve processes to your brain. When it stimulates the somatosensory cortex, you feel the pain. But this emotional component is very important. So I remember back, I think it was Effexor, the first SNRI that came out, and it had an indication for chronic pain as well as for depression. And I remember thinking, how in the world can an antidepressant treat chronic pain? Well, some of it is because of this emotional aspect. So we'll talk about that in a minute. The importance of the emotional aspect is this what really leads to the suffering from pain. And as we think about it, what we want to really treat when we're treating pain is the suffering, not even more so than the physical pain. If we can reduce the suffering, that's important. If we reduce the physical pain, but there's just as much suffering, we haven't helped our patients much. So the emotional aspect actually leads to the suffering from pain. But I'm going to share with you in a minute how we know now, by understanding the brain pathways and how pain works, the emotional aspect actually increases the sensory aspect of pain. It'll take your pain, if you're depressed, if you're anxious, if you're afraid of your pain, it'll increase the physical pain you're feeling from what should be a 3 to a 6 or to an 8, because there's this feedback system in the brain that actually turns up the volume. So we'll talk about that in a little bit as I go on. It's also important to understand there's also a cognitive aspect. Now, this isn't in the definition, but it's clearly understood by everybody. We understand it as the placebo effect. If you have somebody with severe pain, with chronic pain, even with acute pain, and you give them a sugar pill, and you tell them this pill is going to really reduce your pain, their pain will decrease on average by about 20%, just because they believe it's going to help. The opposite of that is the nocebo effect, and we see that sometimes. I think our dental friends do that more than we do. They'll do a procedure, and they'll tell the patient, you know, when you go home, you're going to really hurt bad, right? So when they tell them that, that increases their pain about 20%. So what we think about pain, this cognitive aspect, actually does have an effect on how we physically feel the pain. So that's important also. And so I want you to kind of remember those, because as we go through and we talk about treating pain, we're going to talk about treating all 3 realms, the sensory, the emotional, and the cognitive aspect of pain. And by treating all 3 realms, we have better results, and we have better recovery from pain. So I like to note that there's 4 types of pain. There's nociceptive pain, there's neuropathic pain, there's central sensitization. We're going to spend some time talking about that, and there's opioid withdrawal. So we all understand nociceptive pain. It's the way pain is supposed to happen. You have tissue damage. The tissue damage activates the nociceptive nerve fibers. They send the signal. It ends up going to our brain. Our somatosensory cortex is activated, and we feel the pain. That makes sense to us. Neuropathic pain, we all understand that as well. There's damage to the nerve process that's carrying that signal. That activates those nerves, and it makes them feel pain, but it makes them feel pain where the nerve process began. So again, you think of a herniated disc. Even though the problem is in the back, we feel the pain in the lateral side of our foot. So we all understand both neuropathic and nociceptive pain. Central sensitization is the type of pain that we haven't gotten much education on. And that's problematic because in chronic pain, it is oftentimes the major driver. And in fact, for most people with chronic pain, it might be the only thing causing their chronic pain. So I'm going to spend a little time talking about that. I'm not going to spend much time on opioid withdrawal pain, but it's very important to know that people that are on chronic opioid therapy, if you try to reduce their dose, or if they take too many pills during the month and they're running out at the end of the month, their withdrawal symptoms causes pain. And it causes pain in an area where they've had pain before. So if they have chronic back pain, if you're treating their chronic back pain, as they decrease their dose, their back pain is going to get a lot worse. Now, they will see that. They will imagine that their back is actually worse, that they've got more problems in their back. But it's actually the opioid withdrawal. It's a normal physiologic thing. It happens, you know, for several weeks or so. But many of our patients will also tell us if they're on chronic opioid therapy and we talk to them about decreasing their dose or about weaning them off, they'll say, oh, no, there's no way I can do that. I've tried that before. My back is worse than ever. I just can't stand it. Well, we have to get them to understand that's part of the process. An interesting thing with opioid withdrawal pain is it won't necessarily just be in their back when they're hurting. They did a study on people with chronic low back pain who had been on opioids, and they weaned them down, and they had them fill out a symptom chart every day. And they found that people that had a history of a shoulder pain many years ago, a shoulder problem, they had shoulder pain now that developed also as they weaned off. People that had dental pain, they start having mouth pain as they wean off because their brain has this memory of these previous pains, and it's all activated and comes back as they're weaning off the opioids. So again, just something we need to understand. If we have patients that are having pain for some reason, I tell dentists this all the time. If they're seeing somebody at the end of the month, they're complaining of dental pain, they can't find a problem, it might be that if they're on chronic opioids that they're just running out early and it's causing their pain. So it's also very important to understand that acute pain and chronic pain are 2 completely different things as we talk about this. So acute pain lasts less than 3 months. We can almost always identify the source of tissue damage. It's the pain that makes sense to us. As the tissue heals up, the pain gets better. Acute pain serves a purpose. It's important for us to feel acute pain because we pay attention to what the problem is. We take care of it and help it get better. Two conditions we know of where you lose the feeling of pain. One is diabetic neuropathy, right? So these people will get sores on the bottom of their feet. They get infected. The infection spreads, and ultimately they end up with an amputation because they couldn't feel the pain in their foot. Another one that we don't see much here but is common worldwide is leprosy, Hansen's disease. Those people also lose the ability to feel pain. And so you see people with Hansen's disease or leprosy who are missing fingers or hands or feet, and it's because of the same thing. They get an infection, they have an injury, they don't take care of it, and it progresses to the point where they lose part of their limb. So acute pain is very important. It's important for us to survive. We're going to talk a little bit in a minute about how the brain helps us with that survival. But chronic pain is different. Chronic pain is much different from acute pain. They're two completely different things. We think of chronic pain as just acute pain that goes on a long time. But with chronic pain, it's much more vague. So you have somebody with chronic low back pain, you ask them where they hurt, and they'll commonly, motion over the whole lower back area because they can't pinpoint one place. If they might bring in their MRI and say, look, I've got a herniated disc. Well, if that was the problem, they should be able to say, it hurts right there, but they can't do that. Chronic pain is much more vague. People with chronic headaches, they say, my whole head hurts. Chronic pain is more vague. It's harder for us to find a source of it. For that reason, it's harder for us to treat it. And people respond to chronic pain in a way that makes the pain worse. For acute pain, we respond in a way that makes it better. But with chronic pain, it's just the opposite. People with chronic pain are less active. We know that no matter what the cause of chronic pain is, activity, exercise helps people. So people with chronic back pain, though, they start to stay at home. They're less active, making their back pain worse. As it gets worse, they become less socially active as well. Now they're not going out with friends. They're not, they don't go bowling anymore. They don't play basketball anymore. They stop going to church, and they spend all the time in their house. They're outside in the light less. So all these things actually make depression worse, and we know depression also now drives pain and makes pain worse. So the whole way they react actually makes the chronic pain worse. And by doing that, as the chronic pain gets worse, they have more of those reactions, and it begins this kind of repeating cycle of getting worse and worse and worse. So chronic pain is different. We actually know that chronic pain is caused by some changes in the neurologic processes in the brain that makes them respond this way and makes the pain chronic. So as we really think about it, acute pain is a symptom, but chronic pain is a disease. So again, we need to stop thinking of chronic pain as just being a long-acting acute pain. They are two different processes. So this came from one of the family practice journals. I love the drawing, so I use it frequently. This guy stubs his toe, and you see in circle 1 there, the inflammation of the tissue activates the nociceptive nerve fibers and starts that pain pathway. So the nociceptive nerve fibers run all the way to the spinal column. So the ones in your feet are pretty long. They go all the way up to the base of your spinal column. They go in the dorsal horn, and they connect there to the second nerve, which is the spinothalamic nerve. The spinothalamic nerve then carries the signal all the way up to the base of the brain. You see in circle 4 at the top, it ends in the thalamus. And in the thalamus, it makes a connection to the somatosensory nerve that goes to the top of our brain, and when that nerve is activated, we feel pain. That's the important nerve. When that's activated, we feel pain. People with chronic pain have activation of this nerve, too much activation of this nerve that makes them feel the pain when they shouldn't. So that's kind of the nerve pathway, the way we were taught about it. But you'll notice in that top picture in the thalamus, the signal is sent to other nerves also that go to other areas of the brain. So I wasn't taught about that in medical school. I was just taught about this linear pathway, but it sends it to many other areas of the brain. And the purpose of that is so that your brain can make an interpretation of the pain so you know how to react to it. And it does that automatically, and it does it by actually turning up the volume of the pain, making it hurt more if the brain thinks it's something you should pay attention to, or it turns the volume down if it thinks it's something that you shouldn't pay attention to. So we've all experienced playing ball or tag or something with our friends, and we stub our toe, but we're having a great time. It doesn't hurt too bad till we get home. There was a story just a couple weeks ago about a pro athlete, a pro football player, a lineman, who got injured during the game. He broke 2 of his vertebrae in his back, but he continued playing the rest of the game. Then after the game was over, he started to feel the pain that got so he could hardly walk, and he's going to miss the rest of the season and maybe next season. But because he was so involved with the game, his brain turned that volume down so he didn't feel it. We hear about that in people in war, how they can get shot and they don't realize till sometimes hours later that they have an injury because their brain has turned that volume down. So that's important for us to understand. Central sensitization is where that whole process gets messed up, and we're going to talk about that. But we need to understand that pain is not a linear pathway. There's a lot of other things that are influencing how we feel the pain. And again, that involves our thoughts and our emotions, and that's why we need to address those areas. So I've been talking about this for about 5 years now, and it was hard for me to get some people to believe that your brain really does makes big changes to how you feel pain. But our brain does that to all sensory input. So I use this example now of how our brain changes what we perceive based on how the brain thinks we should perceive it. So in this diagram, or in this picture here, square A and square B are the exact same shade of gray. And yet your brain looks at that and says, no, square B should be a light square, or even a white square. Square A should be a dark square. So it's changing how you perceive that. So even knowing those are the same colors, you can look at that and you can't make yourself believe that. You can't make them look the same because your brain is changing that. But it's changing it because of all the surrounding things that are going on and affecting what it thinks. But as you take some of those away, as you start to take away the surroundings, the colors become closer and closer together, until finally it gets to where they are the same color. And so this is actually cut out of that first slide I show you, because the first time I saw this, I thought, now they're changing those colors as we go along. So I'm back to the first slide, and I did a cutout of the two squares, and that's actually them. But your brain was changing that. It does it for all sensory input. It does it for our hearing. That's why you can be in a crowd of crowded people, and you can talk to the person right in front of you and hear what they're saying, but you're not paying attention to the people around you, and you have no idea what they are. My wife says that's probably what happens at the end of the day when I come home, and she tells me a story about what she did during the day, and the next day I have no idea what she said, because my brain tuned it out, and I blame it on my brain. I said, I tried to listen, but my brain wouldn't let me. So it does it for all sensory input. So this is a diagram. This is my own drawing, so I apologize for the artwork. But it kind of shows how this process works. And so it shows the nociceptor nerve getting activated, sending the signal to the spinothalamic nerve, sending the signal to the thalamus, and then the thalamus sending it to multiple areas. Now, the one in the middle is the somatosensory nerve. And again, that's the important one. When that one is activated, we actually feel the pain. I pulled out, the brain sends it to a lot of areas, but I pulled out the ones I think are most important. So our amygdala is our fear center. If we are afraid of whatever caused the pain, or if we're afraid of the pain, it actually turns the volume up. If it's something maybe we've experienced before and it's no big deal, it turns the volume down so we hardly feel it. The next one there is our hippocampus, our memory center. If we have memories of this pain as being problematic, it turns the volume up. If we have memories of it being no big deal, it turns the volume down. The limbic system, our emotional system, again, if we're having a great time with friends, if we're having fun, if we're playing ball, it turns the volume down. And yet if we're depressed or we're anxious, it turns the volume up. Finally, I have the prefrontal cortex. That's the rational thinking. That's the placebo and nocebo effect. What we're thinking about the pain, our cognitive thoughts also has this impact where it turns that volume up or down. All of those go back and either increase the signal to the somatosensory nerve or decrease it. So it's not that the change in pain is imagined. The change in pain is real. You have more activation of the somatosensory nerve, so you have more pain, but it might be magnified in some ways, or it might be less than we think it should be. So that's why some people can have minor injuries and react in a very dramatic way, and others can have pretty major injuries, and they act as though they hardly feel it. In central sensitization, this whole system goes crazy, and everything turns up the volume. It's always turning up the volume. So you'll see in this diagram, I don't even have arrows coming from the nociceptor nerves because there's some chronic pain where people don't have any problem where they're hurting. The classic one is fibromyalgia. So, I remember back when I was doing the wide range of primary care, I saw a lot of pain patients. I saw a lot of addiction patients. So my wife is a behavioral therapist. We worked together, and we worked with a lot of these folks that some people considered more difficult. But in fibromyalgia, you have no input from the nociceptor nerve. So I remember I would have fibromyalgia patients come in, and they'd say, boy, I'm really having these muscle pains today. It's been a whole lot worse. It's driving me crazy. And I'd get my syringe, fill it up with xylocaine, and I'd inject their trigger points. And they'd go away thinking they were feeling significantly better. In fact, it had nothing to do with the nociceptor or even the xylocaine. I could have used water. It was all placebo effect. The needle is a pretty good placebo effect if you stick it in somebody. And so they go away for a while feeling better. But in fact, it was their emotions, it was their fears, it was their anxieties that was driving the pain, and that's what we really should have been addressing. So in central sensitization, you don't need any input for the nociceptor. There might be some, like many people with chronic back pain, maybe have some arthritis in their back that for most of us would be a pain of 1 or 2 that we just live with. But for them, because of the central sensitization, they feel it as an 8 or a 9. And so, you can't cure the arthritis, but if we address the central sensitization, we can decrease their pain better than any cortisone shot is going to do, better than any surgery is going to do. So there's some central sensitization syndromes that are mostly central sensitization. Fibromyalgia, as I mentioned, is probably entirely central sensitization. Chronic headaches, irritable bowel syndrome, chronic neck pain, chronic back pain, interstitial cystitis. To some degree, all chronic pain, because we don't know completely why some people develop central sensitization, but one thing is, if people have prolonged pain, if they have an acute injury that's not treated well enough and they have prolonged pain, that's one thing that can lead to it. Genetics has to do with it. Learning it, from childhood has to do with it. So there's a number of things. But pain itself probably also helps develop central sensitization. So most people with chronic pain have some element of central sensitization. Now, it may be very minor, and in those people, they're not coming to see us. The ones that are coming to see us because their life has been changed by their pain are the ones that have significant central sensitization. So this is an article that was in JAMA within the past year, and they took patients that were at a clinic that just treated chronic low back pain. And this clinic took 300 patients, and they gave them the radiofrequency nerve ablation, where they go in and actually kill the nociceptor nerves. They do it from the mid-thoracic spine all the way down to the sacrum, so they cover the whole lower back. They kill all the nociceptor nerves. So theoretically, that should treat their pain. So they do that, they give them an exercise program, and they took another 300 where they didn't do the procedure and just gave them the exercise program alone. And what they found was that after 3 months, there was no difference in pain between the two groups, even though half of them had no nociceptor nerves that function in their back anymore. And so the reason why that happens is because most of these people had central sensitization as the main driver of their pain, and until we're addressing that, their pain is going to continue. So as you look at the types of pain and the causes, I added this at the bottom that probably most people have this combination of chronic pain. So when I do a chronic pain consult, that's one of the things I do is I try to decide how much of the pain is neuropathic, how much is nociceptive, how much is central sensitization, how much is opioid withdrawal if they're on opioids. Because we treat those all differently, and by understanding those differences, we can have better outcomes with people. So as I said before, my belief is that most people that are coming to see us in the primary care clinics for their chronic pain, central sensitization is a major driver, and we need to be addressing that. So that's my quick primer on pain. I've got an hour, so we have to do this all real short. Let me spend a few minutes talking about opioids. So again, I don't think we get a very good education on opioids. I hope you'll have a better understanding after this. Opium comes from the poppy plant. It really is a very beautiful flower. After the petals fall off, you'll see in the middle of the slide here these seed pods. They're about the size of a golf ball. And the workers go through the field and they cut those open. And they squeeze out this latex-like material, and that's the opium. So opium has been harvested for, the Sumerians wrote about harvesting poppies and opium 5,000 years ago. So it's been used for a long time by humankind. And the Sumerians actually wrote about using it to treat anxiety and depression. Hippocrates wrote about using opium in 300 BC. He used it to treat anxiety. Neither one of these groups used it to treat pain like we do. So that's important as we talk about what opium does to us. Now, interestingly, in the seed pod, obviously, are the poppy seeds also. And these are the poppy seeds that are on our poppy seed muffins and bagels. And so these folks that harvest these, and it's almost all done illegally in Mexico and Afghanistan, they sell the seeds to food companies. They try to wash all the opium off, but they can't get it all off. And so that's why if you have a sensitive enough drug test, the ones I do at my clinic, if a patient eats a poppy seed muffin that morning, they're going to test positive for morphine because of the residual that was on the poppy seeds. So opium itself is 80% morphine and 15% codeine. Those are the two original opiate medications. All the other ones we use are either derived from those, made with changes of those. The third one, the 5%, the other 5% is thebaine. We don't use that so much, but we do use thebaine as a direct precursor to oxycodone. We use these three substances to make a lot of our different drugs. Some of them are completely synthetic, as you know. Methadone and fentanyl are completely made differently, but they still affect the mu-opioid receptor, so we call them opioids. So opioids are addicting because they stimulate dopamine secretion in the reward center of our brain, and they make you feel good. All addicting substances do that. That's what makes them addicting, is the stimulation of dopamine in our reward center. So when dopamine is stimulated, you feel really good. All of these drugs do it. you'll notice some drugs, that one drug in particular that's not on there is caffeine. We can't really get addicted to caffeine because it doesn't stimulate dopamine secretion. So we may have some withdrawal symptoms. If we drink a lot of coffee and we decide we're going to cut it off and stop, we might have withdrawal symptoms, irritability, sometimes tremors, headaches, some of those things. But we don't crave it the way people who are addicted to drugs crave their addiction. So you'll notice that the last three I have down there, well, the next to the last two are gambling and sex are behaviors. Behaviors also that are addicting stimulate dopamine secretion. So dopamine is important for our survival. It is secreted when we have sex because it's important for us to reproduce. It's secreted when we fall in love. That really good feeling you have when you first fall in love is dopamine secretion in your brain. It's secreted when we win. When whatever we're doing, we win. Our team wins the big game. You know, we win a big contract. We help somebody through a very difficult situation, and they come and tell us, boy, you're just the greatest doctor. That good feeling is dopamine secretion, and it's important for us to strive to accomplish things. So gambling is a form of that reward. So I had a patient one time who was addicted to gambling, and I remember very clearly talking to her, and a new casino had just opened up in our area from the Cherokee Nation, and she had been going out there a lot, and she came to me and we're talking. I said, you know, you need to really get a handle on this. She said, no, you don't understand. She said, I won $40,000 last year. And I said, really? You won $40,000? So as we got talking, it turns out she spent $100,000 to win that $40,000, but she's only measuring the dopamine secretion. That's all that matters to her. The losing doesn't matter. It's the winning that matters. So she became addicted to the gambling because of that dopamine secretion. So opioids are different from other addictions, though. And again, my wife and I, we practiced together for 30 years, and she's a behavioral therapist. She actually started her career in addiction treatment, so it was a big part of what we did. But as we began to see more people addicted to the opioids about 15 to 20 years ago, their stories were different from other addictions. And I didn't understand it at first, but I'm going to explain to you why that is in a minute. But my patients would tell me, they would say, you know, I started on cigarettes when I was in middle school, and in high school I stopped smoking, but I started drinking alcohol, and then I smoked pot. And then I went to cocaine, and I stopped smoking pot and drinking, but I just did cocaine. Then I went to methamphetamine. Then I went to opioids. But I couldn't switch off the opioids. All the other addicting drugs, they could stop and change to something else addicting because they're all stimulating dopamine. But once they got to the opioids, they couldn't go back. It was like this sinkhole. They got there and they couldn't change from the opioids. So there's something different about that. And the difference is that opioids do stimulate dopamine. It's what makes them addicting. But they also activate the opioid receptor. So that's a different system. Alcohol does that to a very slight degree, which is why we can use naltrexone and try to treat people with alcohol use disorder. But it's 10% of what the opioids do. So the opioids activate these opioid receptors, which make them different from all other addictions. And it makes it, first of all, the most addicting substance because of that. And it also makes the hardest one to treat without using opioid replacement therapy. So if you use that, it becomes the easiest addiction to treat because of this opioid receptor. So we'll talk about that and what those do. So, you know, again, I learned about opioids in medical school and how they suppress, you know, too much of it suppresses your respiratory drive, and you end up suffocating to death when you overdose. But they didn't really tell us the whole story, what they do. So our own endogenous opioids are our endorphins. You know, that's what our body makes. And we've all heard about them. We've heard about runners talk about their endorphin high when they're doing a marathon or something. But we're never, at least I was never taught what the purpose of our endorphins is. Why do we have those? And the reason is they help us to achieve a short-term goal. So there have been a lot of studies over the past 20 years on these and the feelings they give us and what opioids do to us. So activation of the opioid receptor does decrease pain. So that's a relatively minimal effect. Again, you think of the marathon runner. They've run 24 miles. By the time they get to mile 24, they're hurting pretty bad. They're sore, they're tired, and then they get this endorphin surge, and suddenly they have less pain, and they can continue going. They also have increased motivation. So our own endorphins give us motivation. They give us confidence about what we're doing so that we will continue doing it and we won't give up. They do increase reward by stimulating dopamine, so they make us feel good about what we're doing. They reduce depression and anxiety, because if we're depressed about what's going on or we're anxious about whatever we're trying to do, we're more likely to give up. So the endorphins reduce those. And finally, they increase something that the scientists call warmth liking, and that's actually liking warm things. It's when you've been outside in the cold, a morning like today, and you come in at the end of the day and you get next to a fire, or you or you get in a hot shower, or you get under the electric blanket at night, that warm, comfortable feeling, that's your own endorphins activating your opioid receptors, and we're supposed to feel that. The scientists use the same term for interpersonal bonding, for the warmth you feel when you're with people you like, working with your colleagues and your coworkers, being with your family. The endorphins and our opioid receptors are vitally important for maternal-child bonding. They've done studies with sheep where the mother sheep gives birth to her baby. They give the mom sheep an injection of naltrexone to block the opioid receptor, and there's no bonding whatsoever. The mom ignores her baby because of that. So our own endorphins are very important for us to be able to work together with each other and to be together and to enjoy being with family and friends. So the scientists call that warmth liking as well. So that's what our endorphins do. And so it's important to understand this because as we give people opioid medications for treatment of their pain, whether it's acute pain or chronic pain, initially it'll activate this system. But as time goes on, our brain responds to it by decreasing our own endorphins and by decreasing our opioid receptors to counteract the action of those opioids. Just like our brain does if we take prednisone for a while. You know, it counteracts by shutting down our HPA axis. And so it does the same thing here. So as we give them over time, initially people feel some of these responses, but as time goes on, it makes it so we can't feel this anymore. So after people have been on opioids for a while, they don't feel confident. They're not motivated to do anything. They have more pain. They have more anxiety and depression. So it causes the opposite effect. And then when we try to stop it, all of that gets even worse. So I call our endorphins and our opioid receptors our success system because I think it's important for us to be successful, to work with others, to achieve, to be motivated, to be confident in what we do. So you all have seen Dorothy and the Wizard of Oz, right? And you remember the story. Dorothy and her friends have been in the woods and all these really bad things are happening to them. You know, the monkeys are chasing them, and the trees are throwing apples, the witch is throwing fire at them, so it's this dark, scary place. Dorothy is lonely and missing her family. She just wants to get back to Kansas. And suddenly they come out to this field of poppies planted by the Wicked Witch of the West, right? And you remember their immediate reaction. Right away, they straighten up. They have this joy because of the activation of their dopamine system, so they feel really good. They have this confidence, this motivation now to go on. They have this feeling of interpersonal bonding, so they link arms, right? And they go skipping and dancing down the yellow brick road. So I call that the Dorothy reaction, because that's all the flooding of the opioid receptor. That's what it does. And I hear this same story in many of my patients. My patients I see for addiction treatment, they'll say, you know, I grew up in a household where our dad abused us, and I saw him beat my mom, my sister. He beat me. She said, we're all afraid to be at home. You know, our home life was horrible. School was not an escape, though. I couldn't get away from it at school because I didn't do well in school. I got in trouble. You know, kids made fun of me. So I dropped out of school when I was in 10th grade. I had a kid by the time I was 18 and another one by the time I was 21. I'm a single parent. I can't pay the bills. It's hard to take care of the kids. Life has never been easy for me. I sprained my ankle at work. Doctor gave me Percocet, and immediately with that first pill, I thought, wow, I can do this. I had this confidence, this joy, this happiness that I had never felt in my whole life. So I hear that all the time from my patients. But the problem is that effect doesn't last. Again, they have to keep taking the pills to get it, but as time goes on, the opioid receptors are decreased, and they end up getting the opposite effect, and they end up trapped in this addiction that's hard to get out of. Just incidentally, you remember what happened. So Dorothy and her friends go down the road, and they start to get more and more tired, right? And they slow down. At least as you recall, it's Dorothy and Toto and the Cowardly Lion, the three mammals that have opioid receptors. It doesn't affect the Tin Man or the Straw Man. Well, I think the Straw Man doesn't even have a brain, right? So they're not affected at all. They're thinking, what are we going to do? So you remember then what happens, how they wake up? Glinda the Good Witch sends snow. So back when the book was written in the late 1800s, snow was a nickname for cocaine, just like it is today. And back at the time when the book was written, this was before the Harrison Narcotics Act in 1918 or whenever it was. You could go to the pharmacy and you could buy morphine, you could buy heroin, you could buy opium just at the pharmacy just by asking for it. You could buy cocaine there. So people would do these drugs at home, or they'd go to opium dens and be smoking their opium with others. And if they had too much, if they're about to overdose, they would snort cocaine to reverse it. Or if they had to go to work or be alert for something, they would snort cocaine to reverse that. So this still goes on today. Again, my patients that I see for addiction treatment, when they first come in to see me, their very first drug test is almost always positive for an opioid and a stimulant, either cocaine or methamphetamine, one of the two. They do them together for that reason. So it's been going on a long time. Our country has suffered with this problem for a long time. So I think the Dorothy effect is problematic. It doesn't affect everybody. So most of us, if we took an opioid, we wouldn't feel that because we have a lot of dopamine stimulation and a lot of endorphin stimulation all the time. Our jobs give us a lot of rewards, and we feel good about what we do a lot of times. But many people do not. If they don't, then that's very problematic. It really increases their risk of developing addiction. I did a survey on my patients about 3 or 4 years ago, maybe 5 years ago now, and I asked them how they felt with that initial opioid that they took, whether it was at a party or whether it was from the doctor, and 85% of them described a reaction like the Dorothy reaction, where they had this new motivation, this energy, this confidence that they'd never felt before. So it's very dangerous if they do develop that. Opioids have other side effects also. So they are mentally impairing. Our folks that are taking them should not be driving. Even people on chronic opioid therapy. A large review recently was done that showed that people on chronic opioid therapy are impaired. It increases their crash risk by a factor of about 4. So they shouldn't be driving. They shouldn't be working in safety-sensitive positions. That's any job where other people's health or your own health depends on you doing your job well. So, it could be construction. It could be the medical field. Essentially, everybody working in the medical field is in a safety-sensitive position. So they are mentally impairing. They actually delay recovery. So I was taught that you give opioids after surgery and it improves recovery because it reduces their pain. But all the studies that have looked at it, and we'll talk about a few in a few minutes, has shown that even beginning with the first pill, the more you take, the more complications you have and the longer the recovery is. They increase medical costs for several reasons. They cause opioid hyperalgesia, and many of you have heard of this, and I've kind of made some mention of this. The opioid hyperalgesia comes from the changes that the brain makes in response to the opioids. By decreasing the opioid receptors, decreasing your own endorphins, it makes some changes in neural pathways and neural transmitters that occur after the very first dose. So scientists have done studies with people, mostly medical students, where they have them put their hand in cold water, in ice water, and they time them how long they can keep it in. They say, keep it in there as long as you can until you can't stand it anymore. And they time them with a stopwatch, and when they can't stand it, they yank it out. They give them a shot of morphine. They wait till it wears off, and they have them do it again, and the time period is much shorter now. They yank their hand out faster. And it's because the morphine has caused changes in the brain that makes them more sensitive to pain. So that begins with the first dose. Now, most of our patients with acute pain, that's not so much of a problem because their tissue will heal up and their pain will get better while they're on the opioids. But for people with chronic pain, that's problematic because we give them a week of opioids, and when they stop, their back pain is worse. And they come back to us and say, it was great while I was on it, but now it's worse. So opioid hyperalgesia is problematic. It probably happens with everybody who's on opioids. This study looked at people injured at work, and it showed that even when you correct for the severity of the injury, for whether they had surgery or not, the biggest thing that made the difference was if they got an opioid prescription within the first 6 weeks after their injury. And if they did, it doubled their chance of being disabled 1 year later. Just that opioid prescription. In the elderly, the study was in people over the age of 65. It showed it increases their risk of fall by a factor of 4. They're 4 times more likely to fall, which, as we know, is a major cause of morbidity and mortality in the elderly. There are GI and cardiac effects. It actually increases your risk of a GI bleed by 20% while you're on an opioid, and it increases your risk of a cardiac event by 50%. So there's a number of reasons why that happens. But again, they are significant for this. One of these studies actually looked at overall mortality and showed that overall mortality is increased by 50% while you're taking an opioid. So I have this, I've mentioned this a couple times, how opioids treat depression. I have it as a side effect because many of my patients got addicted for this reason. They'll say, I was depressed. I've been depressed all my life. Doctors put me on Prozac and Paxil and Cymbalta, and all those seem to help a little bit. They help maybe 25%, but there's always this underlying depression. And, I always struggle, and then I got hurt, and my doctor gave me a Percocet, and I took that first one, and within 15 minutes, my depression went completely away. So for people with chronic depression, that's very remarkable, and they keep taking it for that effect. But what happens is, say a normal mood is up here, kind of chest level. Their mood is typically down here around the waist. They take that pill and the mood goes up to normal, maybe even above normal where they feel some euphoria. But this is a great feeling for them. But as the pill wears off, their mood goes down. So they have to take another pill, it goes back up. But it doesn't go up quite as high the second time because now they're developing this tolerance. And so as it wears off, their depression drops to a deeper level. And so they start this up and down action, but with a general downward trend. So all studies have shown that people with depression who are put on chronic opioid therapy, initially their depression is better, but as time goes on, their depression gets worse than it was before. And even people that haven't had depression, if they're started on opioids for chronic pain, they have a 50% greater risk of developing addiction than people who are not started on opioids for chronic pain. So the depression is an issue. Again, they initially treat it. As time goes on, it becomes worse. It's the same thing with anxiety. They're extremely calming. We'll talk in a little bit about how that's one of the beneficial effects we need to think about with opioids, but it's also a side effect. So our patients with chronic anxiety disorder, they take an opioid, and initially it treats their anxiety, but as time goes on, it gets worse. This study looked at people given an opioid for chronic back pain. This doctor had people come in with chronic back pain. He gave half of them ibuprofen 600 milligrams 4 times a day. He gave half of them morphine 15 milligrams 4 times a day. Did an MRI on everybody's brain, had him come back a month later, and he repeated the MRIs. And then the people on the morphine, he could measure changes in the brain. These are changes to the amygdala, which is our fear center, changes to the hippocampus, which is our memory center, changes to the connection to the frontal cortex, which helps us with rational thinking. So all these areas were becoming damaged, and he thought, oh, crap, we're damaging their brains. He stopped the morphine immediately. He had them come back 6 months later and repeated the MRI, and the changes were still there. And his conclusion was that opioids rapidly and permanently change the human brain. And so this study was just repeated within the past year by someone who him on the previous study and came to the same results, that opioids do change the brain. They start very quickly to the point where we can measure the changes on an MRI within a month. And as we know, they can cause addiction. So we'll talk about that just very briefly also. But now, as we understand pain and central sensitization, we can see why opioids might be problematic in most people. So as you look at this diagram here, you see this is kind of a representation that most acute pain, it comes from the tissue damage itself. Our thoughts and our emotions do affect how we feel that. It does change that somewhat, either making the pain a little less or a little more, but the majority of the symptoms come from the tissue damage. But in chronic pain, most of it is being by our thoughts and our emotions, our fears, our anxieties, our depression. That's what drives the pain, and the tissue input is a much smaller amount. And in some people, again, there's no tissue input. It's all thoughts and emotions that are driving the pain. So as we understand opioids, we give them an opioid. Initially, it's treating their anxiety and depression, and that makes their pain feel markedly better. So they come back and see you in a week and a half, and they say, boy, you are the greatest doctor in the world. I feel better than I ever have. This is wonderful. But as time goes on and their brain becomes accustomed to that and makes the changes and they begin to develop more anxiety and more depression, their pain gets worse as a result of that. And that's why many people on chronic opioid therapy, their pain is worse than it was before they actually started on the opioids. So it explains why people with chronic pain get into trouble. So let's talk just very briefly about addiction, and I won't get into this a whole lot because that can be a whole talk in itself, but I do like to show this study that was put out by the CDC about a year and a half ago, and it looked at insurance claims throughout the entire Midwest, and it identified people who had not had a pain problem and who had not been on opioids previously, and then they either had an injury or they had surgery, and they got an opioid prescription. And they looked at that opioid prescription to see if there were any clues to the initial prescription that would lead to long-term opioid use. And they described that as opioids still being prescribed by the doctor 1 year later. And that's the top solid blue line you see. And what they found was that the most important thing was the duration of that first prescription. Even a one-day prescription, a prescription for 4 pills, gave people a 6% chance of still being on opioids a year later. Now, they didn't look at it in this study, but there's another study looking at surgery patients that showed that if they did not get an opioid after surgery, their chance of being on opioids a year later was 0.4%. So when you look at those two, even a one-day prescription increases the risk of long-term opioid use by about, a factor of 10. And the longer they're on it, the more that risk goes up. As you see, an 8-day prescription, their risk is 13.5%, and a 31-day prescription, they have about 1 out of 3 chance of being on them later. So what they said was, it's very important that the duration of that prescription, starting with the very first day, is very important. And again, it's because of these brain changes that occur, and we need to be understanding that every single dose of opioid we give is dangerous, and we need to kind of be reconsidering how we do that. Interestingly, they also looked at which drugs, which particular opioids were more problematic. And first of all, the long-acting ones were much more risky of people being on them long-term. So they basically have said, don't ever give long-acting opioids for acute pain. But otherwise, they looked at which one of the opioids was worse, and it was tramadol. Tramadol had the highest risk of being on opioids 1 year later. You had about a 13% chance of being on an opioid a year later. And that's because Tramadol is different. So when it came out, I remember, again, the drug rep telling me this is not addicting, this is a safe opioid to use, you can give it to anybody. But we are seeing more and more people become addicted to it. It does work on the mu-opioid receptor, which makes it addicting in that way, but it also is a very powerful SSRI, and we all know that some people have a hard time coming off SSRIs as well. So that combination makes it particularly hard to stop. This study looked at children given an opioid prescription before 12th grade. And what it found was that if a child received a legitimate opioid prescription by us or by the dentist, it increased their risk of future drug abuse by 33%. And if they identified these children as low risk, meaning they came from a family that had 2 parents, there's no family history of drug use or of substance abuse, and there's a negative connotation of drug use in the family, it increases their risk 300% of abusing drugs later on. And we've known this for all addicting drugs for kids. We know if kids in middle school and high school start drinking alcohol, they're much more likely to develop alcohol use disorder or other addictions. Same thing with cigarettes. If they start smoking cigarettes, it's because of the formation of their brain and the effect it has on the reward center and the changes it makes there. Any addicting drug used in childhood increases the risk of addiction later on. For some reason, we thought opioids might be different, but they're not. If we give a legitimate prescription, it increases their risk. So what do we do? Obviously I've talked bad about opioids this whole time. What do we do? So these studies are from the Cochrane organization looking at treating acute pain. So I'm going to talk about acute pain first. Again, I want us to think of pain. Acute pain is different from a chronic pain. All of these are post-op studies. These are people that had surgery. They're in the recovery unit, and they give them either the medication or they give them placebo, and they ask them later how they're doing, and the goal is to reduce pain by 50%. So if they say their pain is an 8 and it drops to a 4, that's considered successful treatment. People are happy with 50% pain reduction. 30% pain reduction, they notice it, but they're not happy with it. So the goal is 50% pain reduction. They looked at a number of different drugs. I included just some of them here, but they've looked at a whole lot. 200 milligrams of ibuprofen, 37% of people say their pain is reduced by 50% or more. Pretty good for one over-the-counter ibuprofen. 500 milligrams of acetaminophen, 28% of people said their pain is reduced. So one extra strength Tylenol, I thought that was also pretty good. You double the dose of ibuprofen to 400, and that only goes up to 40% of people. You go up to 600, that only goes up to 42% of people. So what Cochrane showed, what their organization said, was the higher doses of ibuprofen don't necessarily help pain better. Now, if there's a lot of inflammation, they might help the inflammation better, so you might need to use high doses for that reason. But if we're just treating pain, the low doses do very well. And the low dose, 200 milligrams 4 times a day, has a side effect profile of placebo. It's very, very safe. So think about using the lower doses when necessary. Oxycodone, 15 milligrams, only 21% of people claimed adequate pain relief. Now, many of them were probably calmer because it is very calming. And many of the providers maybe interpreted that as better pain relief, but actually as far as reducing the sensory pain, it wasn't very good. The drug companies know this, so they combine acetaminophen with oxycodone. So the next one is roughly 2 5-milligram Percocets with a little extra acetaminophen. And it was no more effective at reducing the pain than one over-the-counter ibuprofen. So what they do in Europe, they combine the ibuprofen with acetaminophen and give them at the same time. They actually have a combination pill that they can give there. And they give 200 milligrams and 500 milligrams together, and 62% of people have adequate pain relief with that. So I urge you to try this yourselves. If you have an acute pain problem, try this combination. I promise you it works. I do this myself. I carry ibuprofen and acetaminophen with me when I travel. It works very well. My patients love it. So, in my addictions treatment, I tell my patients when they first come in, I don't want you getting opioids from any doctor. If you have pain, we're going to use this combination to treat your acute pain. If you have dental work, even if you have surgery, I don't want you to go home with opioids. We're going to treat your pain with this. And we're going to be checking on the PDMP to make sure that happens. So it does work. So I'll kind of quickly go through this. I think Norton Healthcare is using what we call enhanced recovery after surgery protocols after some of their surgery. This study that I cite here was in the Journal of American College of Surgeons about 3 or 4 years ago. And it looked at people having colorectal surgery, and it compared how they used to do it with the typical post-op treatment with the new enhanced recovery after surgery protocols. And the protocols involve a lot of things. The most important thing is this middle one where they use multimodal analgesia and avoid IV opioids. They don't give any IV opioids after the surgery. They give ketorolac, and in this study they gave IV acetaminophen, both of them IV on a scheduled basis until they're taking PO, which is much faster because they're not getting opioids afterwards. When they're taking PO, in this study, they switched to Celebrex and acetaminophen. And then they had a PRN order for 5 milligrams of oxycodone, QID, PRN for breakthrough pain, not controlled by the other mechanism. And so using this protocol, they found that 77% of people ambulated on the day of surgery compared to 0% the way they were doing it before. Morphine equivalents dropped considerably. That 63 milligrams is the equivalent of about 8 of those oxycodone tablets that they got post-op. Complication rate was cut in half. Opioids are very potent immunodepressant drugs. And so they found that the post-op infection rate was cut in half and the post-op falls were cut in half. Hospital stay was reduced by 2 days. Hospital costs were reduced by $7,000 per patient. And most importantly, probably the Press Ganey patient satisfaction score soared. People loved having their surgery this way in their post-op care like this. You know, we always think we stop using opioids, people aren't going to be happy with that, but people do like it. So, you know, I'm one, I've got Crohn's disease. I've had a lot of problems with that for the last 20 years. But the worst part about it, as far as pain goes, is that it makes me more susceptible to kidney stones. And I get kidney stones all the time. And I used to get morphine all the time. Now I demand the non-opioid treatments, and it's much more satisfying. I think the pain relief is better. I'm not getting gorked out. I get out of the hospital sooner. So it really works with all kinds of things. I'm going to skip that. That's just a study that showed the same thing with renal colic, that morphine was the least effective. This study I like to show because it was actually done by a drug company. It was done by the company that makes tapentadol, which is Nucynta, and they had received an indication for use for chronic pain, and they wanted to get an FDA approval for use for acute pain. So this is studies in people that had their wisdom teeth out, and they looked at all of their different doses of tapentadol, one-time dose after they got done with surgery. But they also had a comparator with ibuprofen 400 milligrams and morphine 60 milligrams, as well as placebo. And if you look at the one at the top that reduced the pain the most, it was the 400 milligrams of ibuprofen. Better than 60 of morphine, better than all the doses of tapentadol. So their conclusion of their study was that tapentadol reduces pain more than placebo does. They didn't mention that ibuprofen's a whole lot better. The FDA gave them approval to use for acute pain, and soon after that, I actually had a good friend who was prescribed tapentadol by his doctor, one of our chief sheriff's deputies, and he went home that night, took his tapentadol, had a couple beers, and he didn't wake up the next morning. He overdosed on the tapentadol. So, you know, a dangerous drug giving approval when 400 milligrams of ibuprofen would have done better for him. These are just a couple of studies that looked at if people have an acute pain problem, what is the leading reason why they develop chronic pain? What they found was that anxiety and depression prior to the injury was the leading cause. So again, our mental health, even for our acute pain, but also for our chronic pain, is something we need to be considering. And interestingly, the least important was the severity of the injury. So when you look at what we can do, it appears that giving of opioids is the most important thing that leads to long-term pain if we do that. People will develop more long-term pain if we prescribe opioids. So as we think about acute pain, you know, we just have to reduce the opioids we prescribe for acute pain. The CDC guidelines, you know, I was a part of that development. I worked with the expert panel. It was really cool. We found that they decided on 3 days or less for pain regardless of the severity. But what they said was that, you know, in many cases, no opioids are necessary. And I think that's the case for outpatient treatment of pain in particular. And this combination is most effective. Josh, can I have like 5 more minutes? Almost done. So chronic pain is differently. So I'm just going to touch on this quickly, but I want you to think of it differently now. Think of it as being driven by our thoughts and our emotions. So first of all, we have no evidence that opioids work for long-term pain. The epidemiologic studies show that people have worse outcomes on them. The American Academy of Neurology has said we shouldn't use opioids for chronic back pain, chronic headaches, or fibromyalgia. Those are mostly driven by central sensitization, and they're going to get worse on the opioids. So what do? Behavioral therapy, because this is a behavioral disease, actually, is the most effective treatment. It has the best science base as far as what is effective. CBT and mindfulness, they change how people think about the pain. They have less catastrophizing. It's very rewarding to see people go through CBT. There aren't a lot of counselors that do that, so you need to find a therapist that can do that. It's kind of a specialized, very structured type therapy, but it is really cool. Physical therapy, occupational therapy, and speech therapy. I see one of the sponsors is a physical therapy group. You know, a lot of what the physical therapists do, it's not just their movement, but it's showing people that they don't have to be afraid of their pain. And by reducing that fear, it reduces one of the drivers of the pain. So all of the therapies can be important. Treatment of mood disorders, since depression is driving it. Exercise helps. Acupuncture. You know, these medications, there are non-opioid medications that help a little bit, but all the studies show they reduce pain between 10 and 20%, which is not great. People are not happy with that. So medication shouldn't be the standard of treatment. It needs to be these other things. So really, my summary for chronic pain is if we want our patients to have the best outcome, we need to get them out of our office. You know, we're not going to do them much good. It's the therapists that are going to be doing the good for them. So as we think about it, we all live in this big blue circle of life, and everything that is in our life is in this circle. Our family, our friends, our hobbies, what we like to do, what our fears are, all of it is in there. We develop chronic pain, and we have this little blotch that affects our life somewhat. But because of the way we respond to pain, by staying at home more, by going out less with our friends, by doing less with our family, our life begins to shrink around the pain. And we've all seen patients that have done this until pretty soon the pain is almost everything in their life. And that's all they think about, and their life revolves around it. Their family's life oftentimes revolves around it. So the physical therapist, they will tell the patient, our goal is to give you your life back, is to make your life better. They will oftentimes won't even talk about reducing pain, but we know that by reducing their depression, their anxiety, increasing their activity, all this stuff, that red dot shrinks as well. Their pain is actually reduced, but their life is made better. So that's kind of the goal. That's what our therapists do. Just quickly, CDC guidelines, that's what that reference, but I like to show this new VA and Department of Defense guideline that came out for treatment of pain last December. And the very first recommendation, they said, we recommend against initiation of opioids for chronic pain. So we shouldn't, you know, my thought is the great majority of people, we should never be starting them. I do like to say there's 2 times when they're definitely indicated. Following severe trauma, studies of our soldiers in the battlefield have shown that if they have a severe wartime injury, the sooner they get the morphine, the less likely they are to develop PTSD. And if they do develop, the less severe it is. And that's not because of the pain-relieving qualities, it's because of the calming qualities, because immediately it calms them down. So opioids do have this beneficial effect that can be used after trauma. They've shown the same thing with burn patients, that severe burn patients, the sooner they get it, the better outcomes they have. But if opioids are prolonged past 7 days, they have worse outcomes. They have longer recovery periods, they have more depression afterwards, and they have a harder recovery. So a limited time period. And obviously, end of life when people are dying. I will say we need to be careful with our cancer patients. 2/3 of cancer patients will be cured of their cancer, and about up to 20% of them will remain on opioids afterwards because they can't get off of them. So we need to be really careful with those folks. So, you know, here's kind of my conclusion. We've gotten so used to just writing a prescription for this, and that's probably the worst thing we can do for most of our patients with chronic pain. We need to be talking to them. We need to be getting them to the therapist. That's my contact information. I kind of rushed through all that. Do we have time for any questions? Or I think we have time. According to my thing here, we've got 1 minute. So any questions or comments? Yes, sir.
You make a comment about pain scales.
Yes. So comment about pain scales. So yeah, we've been using those for a while. If you have patients in chronic pain, I think it is important to kind of keep track of that, but that shouldn't be what drives our treatment. So the CDC guidelines, if you go to their website, they actually have reference to what they call a PEG scale, which is PEG. That's for pain, enjoyment of life, and general activity. And it's a scale of 0 to 10. Your patient can circle when they come in on how much has pain affected your life in the last week, and they circle the number. And the next one is how much has pain affected your enjoyment of life. They circle a number. How much has pain reduced or affected what you're able to do, and they circle a number. So you get 3 different things that measure pain, quality of life, and function. And I think that's more important to be monitoring. In particular, if we put people on opioids, because over time, almost all of those things will get worse, and they can see that they've had a downward trend. But also, if you're doing behavioral therapy, maybe the pain score will stay the same, but their enjoyment of life is going up. And you can show them. You can say, look, you're doing so much better than you were before. Yes, sir. No, so, you know, I don't talk about marijuana particularly because I like to have all of what I talk about be science-based, and there just is not good science on the effect marijuana can have. All the studies have been very small, and they have been conflicting as far as their outcomes and what they do. Now, I do think there's some potential, but I think it needs to be studied a whole lot more. I think we need to be looking at that a lot more. And, you know, any addicting substance, you know, I think we need to be very cautious if we're using it to treat anything. So I will hang around in the back for a little bit afterwards, but that's all I got. So thank you very much.